Welcome. I'm Stephan Achenbach, European Society of Cardiology. It is April 7, 2020, and I'm very fortunate to be here with Professor Tobias Welte, who is a professor of pulmonology and infectious diseases at the Medical University Hannover and also past president of the European Respiratory Society. Thank you very much for being here with us, Professor Welte.
It's a pleasure. Thank you.
And we have an important topic today. We want to talk about ventilator therapy in patients with COVID-19. Obviously, something that dominates our workday globally almost at the moment as cardiologists, and some questions we would like to address in a very brief format, as we have always done in this video series. What can we do before intubation or to avoid intubation? What are the criteria to initiate ventilator therapy, intubate our patients? What are the basic respirator settings? What about proning? We hear a lot about proning. And finally, important questions regarding fluid management. So let's get started right away. And the first question is, of course, we would like to avoid intubation in our COVID-19 patients. So Professor Welte, in our hypoxemic patients, what can we do before intubation or to avoid intubation?
So there are two main options, which is high flow oxygen therapy and non-invasive ventilation. In Hanover, we prefer high flow oxygen therapy. The patients are normally only hypoxemic. The hypercapnia is a very rare feature, and high flow oxygen is easy to apply, and the aerosol spread is not as high as with non-invasive ventilation. Non-invasive ventilation can be very difficult in these patients if the patient does not tolerate the mask, and then there is a huge spread of aerosols, which is of risk for the staff.
Protecting the staff is extremely important, obviously.
Yeah, absolutely. So protection of the staff is one of the most important issues, and everything what we do should be done by taking staff protection into account. The main question for the future is there early pharmacological treatment? What is a mess is that all the studies which are now in place for COVID treatment are in advanced stage, very late during the disease process. However, if you use it to avoid intensive care admittance and intubation and ventilated, you must be very early. And early treatment may be antiviral treatment in comparison to late treatment, which is normally anti-inflammatory treatment. So we need studies in this more early phase of the disease in the future. A very short word, what are the risk factors for deterioration? There are some biochemical parameters, most important, the amount of CRP, C-reactive protein, and the most sensitive parameter for deterioration is lymphocytopenia. Mm-hmm. If the lymphocytes are going down, and they are going down in longitudinal measures, this is a clear signal for deterioration of the patient. In addition, LDH and ferritin, this should be measured because these are parameters of hyperinflammatory response, and the patients with a hyperinflammatory response, they all deteriorate, and they should be admitted to the ICU very early.
Very early on. So what are the criteria to intubate a patient and to initiate ventilator therapy?
If patients deteriorate, even they are treated with high flow oxygen, so if they are more hypoxemic, if extrapulmonary organ failure occurs, and the second most important one after respiratory failure is heart failure. Mm-hmm. About 20% of the COVID patients have, I would say, signs of myocarditis. And if this occurs, the prognosis is worse, and this patient should be admitted to the intensive care unit. What most often could be seen is dizziness or a kind of delirium. This almost is a sign of deterioration, and these patients should be intubated early, because if they are very dizzy, they spread a lot of aerosol, and again, this is the risk factor for the staff.
Once again, a very important point. Now, once the patient is on the ventilator, what are the basic respiratory settings that you should keep in mind to do things right in these patients?
Yeah, that's an easy message and a good message. These patients are very easy to ventilate. You use the classical settings for protective mechanical ventilation, which means low tidal volume, low driving pressure. The patients only need a moderate PEEP, so 8 to 10. If you increase the PEEP to higher levels, this seems to be not very helpful. And then prone position is our favorite measure.
In fact, we hear a lot about prone positioning, particularly in these patients. Can you tell us something about it?
COVID is different from, for example, influenza, pneumonia, or bacterial pneumonia. In the latter ones, the main pathological issue finding is alveolitis. But in corona, the main finding is capillaritis, a kind of vasculitis. And therefore, capillary leakage occurs very early, and there is an increase in extrapulmonary lung water. If you put the patients into prone position, you change the perfusion ventilation ratio, so the less perfused lung parts are now less ventilated, and the better perfused ones are better ventilated, and this leads to a rapid and very big change in gas exchange and PO2. So early prone positioning is one of the major treatment options.
Oh, that's perfect. It's always difficult to ask for numbers because every patient is different. But is there an inspiratory O2 concentration above which you would recommend prone positioning? What would be the approximate level?
So we start if the patient has a FeO2 of 0.5. So
0.5. So that's very early.
Yeah, very early. And then we put them into prone position for 48 hours. So I did not see one patient who did not improve with this. And then we put them back on the back after 48 hours and look what happens. About half of the patient deteriorates again, and then they are put back to the prone position. But half of the patients is stable in back position, and then we start the weaning process.
Well, that's another very important piece of information I would like to spend some time on, because conventionally we hear and read that 16 hours per day is in the prone position and 8 hours on the back, but you do it differently.
We do it for 2 days, and look what happens. One of the miracles of corona disease is that this is a wavy course of the disease. So patients improve and then they deteriorate again. Then there is something which is a hyperinflammatory syndrome that could last for hours, but only for days. Then they improve again. So it's a very, very fluctuant course of the disease. And this is something you have to have in mind. So some patients, after being ventilated, after being in prone position, improve after 3 days, and then you can start the weaning process. But the mean ventilation time in our ICU is about 14 days.
14 days.
Yeah,
that's what we hear. Now, as cardiologists, and especially since you mentioned that this is a problem of the capillaries, fluid management is of high interest, obviously. What can you tell us about fluid management in these patients?
Well, COVID disease is mainly one organ failure, pulmonary failure only. As I said, about 20% have a cardiac involvement, 5% only have a cardiac manifestation.
Mm-hmm.
However, shock is a very rare event. Most of the patients are catecholamine free. And due to this, you can drive the patients dry to reduce extravascular lung water. So in most of the patients, we try to come out with a negative water balance than more than with a positive one.
Very interesting. So are there any further considerations that you would like to share with us regarding ventilator therapy in COVID-19 patients?
The weaning procedure is a difficult one.
Mm-hmm.
And this is because of the wavy course of the disease. So patients are ready for extubation. You extubate them, and then they deteriorate and need re-intubation. And emergency re-intubation is a risk not only for the patient, but also for the staff. Again, because this is an aerosol producing event. Because of this, and because we had 2 negative experiences, we started early tracheostomy in these patients, which make the weaning process much easier. And if you look for the recommended protective strategies, so we use FP2 masks, classes for this, then it is a safe procedure, and we did not see any staph infection, any nosocomial staph infection by the bronchoscopies who were available for tracheostomy. So we do early tracheostomy, and our experience with this is very good.
That's fantastic information. Thank you very much, Professor Welte. This was really truly interesting and very important, some very basic information that is going to be helpful to many patients. So thank you once again for being available.
Thank you, Professor Achenbach.
It's been a pleasure really to have you. I would also like to remind you that we have much more information on our dedicated website, scardio.org/COVID, and I would like to thank you all for your attention.